Okay, we ask everybody to have a seat. We're going to go live to Paris. We're going to be doing a couple of endo AVF cases, the two different devices. You get to see them here at CiDA. And the first one will be Dr. Mallios from Paris. Bonjour, Paris. Hello, Paris.
Bonjour, comment allez-vous?
Oui, tout va bien, tout va bien. Nous sommes prêts. Everybody's ready here. We are very excited to hear what you are going to do, a little about the patient, a little bit about your approach.
Perfect. Don't worry, guys, I can speak English. So we have a 65-year-old patient here that she's suffering from diabetes. As a result, she has renal disease. And I'm going to show you a bit the anatomy that we have here. And I will explain you my algorithm about choosing one method over the other. So as you can see here, this is the cephalic vein at the arm of the patient, an excellent vein, kind of deep, about 5 millimeters diameter. And what you will see here is the perforator going down to meet the proximal radial artery after the takeoff. This is the brachial artery here, and the bifurcation with a larger radial artery and a kind of smaller ulnar artery here. Of course, lots of people might ask why not do a distal. So, for example, this patient, and this explains why distal fistulas are failing in diabetic patients. You see this horrible calcified artery, which is one and perhaps the most important reason of failure for diabetic patients. And on the other hand, you will see a beautiful vein here. That what if we follow this upper in the forearm of the patient? You will see that this patient had previously a perfusion, so this vein is dead. It's not usable anymore. So you might do a beautiful anastomosis here, but your fistula will never work for two reasons. So for these patients, as my mentor, Dr. Jennings, taught me when I was in my fellowship in Tulsa, I started doing the proximal radial artery fistulas because you're still in the radial and see how beautiful and normal this artery looks here in the proximal part, while in the more distal part it's calcified. And in this way, you have a larger vein, a better artery, and also very vessels are very close. The perforator and the radial artery are just side by side, so you can do surgical anastomosis. Now, for the last couple of years, we have Ellipsys, and we can do this percutaneously. And of course, this is a huge advance for the patient. I don't know if Aris has any comments or questions.
Alex, this is Aris. Could you show again the cephalic vein so I can just point it out on the screens, and then the perforator coming down to the proximal radial? Okay,
so this is the cephalic vein right here.
Yep.
Going down, and you will see a short perforator coming down to meet the radial vein and the proximal radial artery here. And if I squeeze a bit, you will see it's the artery that's pulsatile. I will show you again in a longitudinal view. You see the perforator here coming down to meet the radial artery right there.
Right.
Okay, it's the perforator and the last part of the perforator just next to the proximal radial artery.
This is the proximal radial. This perforator does the proximal radial.
Hey, Aris, is it feeding the basilic as well? Is it feeding the basilic as well? We saw this.
No, here we don't have a median basilic at this patient.
You can just talk into him, what he's saying.
Yeah. Okay. Are you guys okay? Can we start the case?
Yeah. Jeff, rock and roll.
You're going to approach this through the median cephalic vein?
There's no median cephalic vein in this patient.
You just speak into the microphone.
Okay, Aris, are you okay? Can I start the case?
Yeah, you can start. Yeah.
Okay, so 3:39 Paris time. We are about to do the puncture. I'm going to puncture a bit higher than the origin of the perforator. I'm going to puncture in an axial view. I'm going to puncture more vertical, and then I'm going to go more parallel to the skin. And then you will see what I'm going to do. I can do it either way, but I found that the transverse, the axial view is more precise. So what I'm going to do, I'm going to go down with my left hand, and slightly, advance the left hand until I don't see the point of the tip of the needle anymore, and then I will advance with my right hand. And then again, left hand, right hand, until I go down, and now I see the perforator, and I will slide in the perforator, making sure that I stay at the center of the vein. I find this technique more precise in order to avoid sticking the sidewall of the vein. And you see that I'm already down, ready to hit the artery. And you see that even if I don't do anything, I just leave the needle to take its natural course, it's kind of pointing towards the artery, okay? And you see I'm start pushing against the artery here. I'm going to show you this in a longitudinal view. You see how beautiful I see the needle into the perforator, and I'm just about ready to get into the artery. I'm start pushing against the artery. And I will feel it going through the resistance of the arterial wall. You see here that I'm kind of at the side of the artery, and this is again what I was saying before, that the longitudinal view sometimes is a bit less precise. So I'm going to pull it a bit back, and I'm going to stay in an axial view, and I'm going to do exactly the same what I was doing before. I'm going to advance and advance the needle in the axial view, staying at the center of the artery now. And now I have pulsatile flow. My resident is going to put the wire in. It should go without any resistance. No resistance, Rami? Okay, perfect. So the wire will go in without any resistance. I'm going to check the distal radial artery to make sure the wire is all the way down, and you see that the wire is all the way down. You see the wire is moving here, so I have absolutely no doubt that I'm in. Once this is in, I'm going to take the tourniquet off because we don't need the tourniquet anymore. We're going to give some heparin. On va faire l'héparine, s'il vous plaît. So so we're about 2 or 3 minutes after the beginning of the case, and the toughest part is already done, which was basically the puncture, and do the puncture neatly without having any hematomas that might make the view a bit more difficult. I'm going to use, as you see here, the dilator of the sheath. This is a 6 French slender sheath. I'm going to use a dilator to exchange the wire. I'm going to take the O21 wire off, and I'm going to put the O14 wire that we need for the device. This is an 80 centimeter O14 wire that's going to go in right now.
How much heparin did you give, Alex?
I gave 3,000 units of heparin now. Most of the time we will give 50 units per kilogram. So I gave him 3,000 units of heparin. And the main reason we give this is because the sheath is kind of occlusive, and you may get some spasm. And I don't want to give anything else. I just want to give it some time, and then with time the spasm will go away, and the heparin will protect you from having any clots or anything. So let me show you something important here. So as my resident Rami, who has now a big experience helping on those, is assisting and putting the ellipsis in, what you want to see when you do these cases is to make sure where the crossing point is. And in order to see that, you will go in longitudinal view, that you see the artery pulsatile here, and you will follow the artery from medial to lateral. You see, from medial, you see here the bifurcation of the brachial artery, the takeoff of the radial artery, and then coming in the sheath. So this is the crossing point, yes? So I'm going to advance the device in until the distal part of the device is right at the position that seems to be inside the artery, and the posterior part of the device is in the vein. Then my resident will pull back the sheath. See? I'm going to hold the device. Resident will pull back the sheath. Perfect. And now you see the artery much better now that the sheath is out. You see how beautifully we see the artery? So I stick the distal part of the device in the artery and the proximal part of the device into the vein. And what I'm going to do next, I'm going to change the grab of the device, and I'm going to pull gently until I grab the artery. You see how I grab the artery? I cannot pull back anymore. I'm grabbing on the artery. Okay, I see it, I feel it. So I'm going to kind of stop pulling, and I'm going to push the button and close the device. to grab the arterial and the venous wall together. Imagine this as a small sandwich. We have the anterior part of the wall, the superior wall of the artery and the inferior wall of the vein grabbed until the two plates of the device. The reading is 0.5. The generator gives us a reading of the distance between the two parts, which essentially gives you an indication about the amount of tissue that is grabbed, which is perfect, 0.5. And once this is done, I'm going to ask the nurse to activate the generator, which will give some short pulse of heating. You see the micro bubbles here from activation of the device. Okay, and now it's cooling. And I'm going to start applying some tension here. And once I feel it kind of gives way, I'm going to stop the procedure because the anastomosis, is it zero? Okay. Fais encore une. So, okay, c'est bon. So we're done. The anastomosis is completed, as you will see shortly. Un ballon de 5, s'il te plaît, Johan. Okay. Est-ce que tu peux mettre le couleur, s'il te plaît? I'm going to put some color here. As you will see, the anastomosis is already completed. You see that we have fistula flow already. We have systole-diastolic flow in the artery. You see this beautifully here, and we have flow through the anastomosis. So essentially, it's 3:46, which is 7 minutes after starting the case, and the fistula is created, the anastomosis is created. Having said that, of course, the device is small in order to avoid a big hole in on the wall of the artery. So this is a small anastomosis. And we realize that it's better to do an immediate dilatation to assist and accelerate maturation. On va enlever la couleur, s'il te plaît, Johan. And we're doing this with a 5 by 2 millimeter balloon. You see the sheath here that is in the cephalic vein. And once the balloon is in, we're going to hold the balloon in place with the sheath, keeping the sheath in this position. We're going to make sure that the balloon is going to come in the radial artery just a bit and avoid to overinflate the radial artery, but you really want the tip of the balloon inside the radial artery in order to actually inflate the anastomosis. So you see that the tip of the balloon is inside the artery, and we are ready to inflate. Vas-y, Rami. So we are inflating, and I'm going to hold the sheath because the balloon we're going to try to push back, and I'm going to hold it with the sheath in place. Vas-y plus. Vas-y. Okay, you see there is some wasting. Vas-y. Vas-y un peu plus. Okay. And you see that the wasting is almost done. Vas-y un peu plus. Okay, dégonfle.
What pressure are you applying?
Nominal pressure, which is 8. This will give you a 5 millimeter, but sometimes, you know, we can go higher to get a 0.5 millimeter more. The rupture pressure of this balloon is 13.
How long do you hold the inflation?
We're doing, you know, a few short inflations, and probably at the end of the procedure, we'll do a bit more prolonged one. So what I want to see everything well dilated from the artery, the anastomosis to the perforator. You see the artery coming in here. You see the artery that is meeting the balloon. So I know that I'm inflating well the anastomosis and the perforator. So I'm going to pull the balloon back with the sheath all together, and I'm going to inflate the perforator a bit higher, vas-y. And now I'm inflating the whole length of the perforator. You see that we were successful in creating a water-tight seal anastomosis because we have the balloon inflating the perforator. There is no hematoma or anything else created around the artery, so this means that we have a good and solid anastomosis. Okay. And I'm going to inflate, you know, without some, you know, specific science or evidence behind it. I'm going to inflate a few times, you know, give it a few inflations until I feel comfortable about the final image I'm getting. And I'm feeling pretty comfortable, to be honest, right now. Okay, dégonfle.
Alex, you're now using balloon inflation of the anastomosis during each case?
Yes, I'm doing it for every case. Reinflate, please. I'm doing it for every case because we didn't have any issues with it. We didn't have any ruptures. So there is only benefit that can come out of it because it will increase the maturation rates, and we didn't have any complications. So we don't see any reason not to do it.
It seems like it may also treat any venous spasm that you might have in that perforating vein. That might be important also?
Absolutely, that's absolutely right.
Do you give any antispasmodics before or during the procedure?
Is this Ingmar?
Yes, I'm here.
No, that
Hi,
was...
Ingmar. Thank you for the question. So I do not. I know that my colleagues, Dr. Hall in particular, gives a cocktail, but I do not. I don't have this habit, even when I do my open cases. So this is why if I have spasm, I will just give it some heparin to give it some time to recover.
He drinks wine, doesn't he?
Yeah.
The operator
We
or the
give
patient?
we give patients some red Bordeaux, takes care of everything.
Hey, Dr. Mallios, it was actually Dr. Dolmash talking to you in the past. I'm the one with the Texas accent.
So Alex, this is
I have a Parisian accent.
Jeff Lawson asking a question.
Hi, Jeff.
How calcified of an artery will you, if you see medial calcification in the artery, when do you back off? What's the kind of boundaries of?
Yeah. So Jeff, I'm going to answer the question. I'm just going to show you what a beautiful result we have here after the
gorgeous.
PTA. You see? Absolutely perfect. And we are 13 minutes after the case, after the starting case, 12 or 30 minutes. So this is not to say, that we're very fast and very awesome, but I think, for logistics and everything, being able to do a case pretty fast and, not being tired after it, it's very good for you and the patient. So to answer Jeff's question, contrary to the most of the vascular surgery procedures that, calcified arteries are a big enemy, we didn't have a problem with calcified arteries here because what happens is we have heated pressure that applies on the artery, and this is applicable without any contraindication in calcified arteries. And actually what happens is that after we balloon them, they kind of stay open instead of having recoil. So we didn't have any issues with the more calcified artery that you can imagine. I remember I did a patient with previous finger amputation, horribly calcified arteries, and we were able to find into it. So I'm not saying, see a patient with a calcified artery and party about it, but I don't think it's a horrible problem to have it when you are going to do ellipsis. I'm gonna measure flows here, although I have the sheath in.
Dr. Mallios, while you're doing that, you took your needle, punctured the vein, then steered the needle through the perforator, and then punctured the artery. In your personal experience, how difficult is it to acquire that ultrasound skill to pass through with the needle through 3 different parts of vascular structures?
So I had to do I had to do 10 patients with the guys from Avenue that came here in Paris to help me. Of course, the first punctures can be challenging because you're starting a case and you say, well, what the heck is just a puncture, I should be able to do it. But it's kind of challenging because you have to go from the vein into the artery. But after 10 cases, I felt pretty comfortable to do it on my own. And this is what I see with my partners. My partners, after 10 cases, I help them. They are independent. And, I know we're pretty awesome guys, but, I don't think we're Superman. I think anyone can do it, after some teaching. And I think what's happening is, especially this axial view, it's so simple because you basically see the vein as a black circle, and you just go down slowly. You make sure that the tip of the needle is in the center of it, and it's just about that. You don't even need to be an ultrasound expert. We're going to measure the flow now.
Okay, I have a question for the audience here. I'd like to see a show of hands. How many people in the audience think that Dr. Mallios is both fast and awesome. It's unanimous. We all agree you are fast and awesome, Alex. It's
Thank
terrific.
you very much. I appreciate it.
Dr. Mallios, you have about 350 people watching you now. How many is this?
Perfect. Freeze.
Is it?
Freeze.
Does that beat your record?
I think this is the best I've ever had. Freeze.
And they all want to come to your meeting in Paris next year. When is that again?
Wow, yes. We have to book a bigger room calculation. Have it the volume. Yes, selection. Oh, no.
Friday 13.
So, Alex, we have about a minute or two left before we switch on to other things.
Perfect. So I'm just going to measure the flow for you while you ask me a question.
Any questions from panel, or what do you have, Rob? Rob Jones from the
Alex,
UK?
hi. Rob Jones from Birmingham, UK.
Hi, Rob.
Hi.
How are you?
Well done. Great case.
Thank you,
Is the
sir.
patient under sedation and IV analgesia, or are they completely awake with local anesthetic?
So what we do here for all our cases, we give axillary block, and we give also some sedation, especially when you do a live case. You don't want to have the patient start singing, but generally we try to give them some sedation, and they all get axillary block. And to be honest, the axillary block is more for the vasodilation and less for the actual pain, because the truth is that for the pain, you can easily do it with local anesthesia, no doubt about it.
And do you need to keep the patient in hospital overnight, or will they go home later this afternoon?
No, it's definitely day surgery, and to be honest, I think in a few years we'll be able to do this in clinics. You see all these things here, we do it in surgery, but I think it's an overkill for sure. The procedure is so simple. If you see, actually, I have a liter of flow here. It's unbelievable. I have a liter of flow. Wow. So,
Are you going to band? Are you going to reduce the flow a little bit?
I don't know. Perhaps, do you want me to take? I don't know. I think it's perhaps I'm going to measure the.
Open the gate.
I overestimated a bit. I opened the gate a bit.
Yeah, open the gate on
I think I'm cheating a bit. Yeah.
Jeff, any comments about outpatient, inpatient, so forth? Because the U.S. trial, I think, was all outpatient, wasn't it?
Right, all outpatient. And I want to, Alex says it took some 10 cases, but you have to realize that this method of going down transverse is not how we taught him. We taught him to put a wire down and to move the needle over the wire. So he independently developed this transverse technique during his, quote, training period. So Alex, you've really moved this technique forward. He also sort of pioneered the all-in-one maturation. So he had balls of steel and just went up there and ballooned that thing.
Oh, he's awesome.
And didn't worry about it. So we were usually just, when we initially used the balloon, we were just treating spasm. There's always recoil and there's always spasm when you put this device in, and we were just trying to affect that. And like I said, Alex took the technique and the overall results to a new level. So thank you, Alex. That was fantastic. And, we do it in the OBL. So a patient will come in at 8 o'clock, and we'll use. I do blocks myself.
Okay.
We use lidocaine, and the lidocaine wears off in about an hour. So the patients will come in at 8. They'll leave by 9:30.
Nice.
With a
You're
fistula.
getting a
Yeah.
reasonable flow volume there. It looks like 505 milliliters per minute. That
Yeah.
looks perfect, huh?
Hey, Alex, it's Eric Peden.
Yeah, and a very low resistance as well, which is awesome. Yeah, this basically what I like to see. It's not so much the actual flow, but the pattern of the flow, because I have very low resistance now. So it means the anastomosis is widely open, and this is pretty awesome. My resident is gonna hold some pressure now. You will see. We're gonna take the sheath off, and we're gonna hold some pressure a couple of minutes, and that's about it.
Perfect.
Somebody wanted to ask something?
Eric?
Hey, Alex, it's Eric Peden. That was really spectacular. It was really awesome. Question to you
Hi,
is,
Eric.
do you ever add in then embolization of the deep vein to try and encourage the flow superficially, or not needed?
Okay, so I never do this. I never do this as a part of the creation. I will basically I will avoid doing a patient that he has a big radial or a big brachial vein because I know that he will take the whole flow. So I will avoid these patients. In some patients now we have done 156. In some patients, after a period of time, you may need to ligate a basilic or a brachial vein, especially if you see that the dialysis center is far away. We get patients that are coming from Guyana or other places. And if it's patients that you're not able to coach them and go there and teach them how to stick the fistula, you want to make it more straightforward, like a more higher pressure surgical fistula, you may need to do some things like that. But it's not the rule. It's rather the exception.
All right, Alex, we're going to have to leave and go on to some other things, but I think I and all of the panelists and all of the audience want to thank you so much for a wonderful presentation.
Thank you so much, guys. See you later.
A bientôt.
À bientôt. Au revoir.